Kruger. I know most of you, some of you don't. PTA here with CEO. I've been with the company on and off about 6 years. Yeah, about it.
I'm Jen. I work in Brantford 469. I've been here for 11, 12 years or so. I'm going to talk about how to get rid of people and give them a good, strong program to continue their long and active and healthy lives.
All right. So objectives are going to be identifying readiness for discharge. So what buckets of need do we have to fill to kind of clear in a systematic process? So not just like, oh, I think they're ready. They've been here a long time. Specific things. Confidence building exercise program for various populations. So the post-course education you guys will get will go into very specific populations. Today it's going to be a little more generic. And we'll kind of touch base on a couple different populations. And then effectively managing setbacks. What do we do? How do we manage it? What happens next? Fast notes. So key concepts for today are going to be, as in the course title, principles, heuristics, and methods. So principles are foundational truths or anchoring premises. We should think of these as what does the intervening. So you want to think Wolff's law, law of progressive overload, something that's a hard truth that's been proven over long periods of time that you don't have any real control over. You can just simply apply and let it be. Heuristics are like rules of thumb or mental shortcuts. So think using a patient's pain to kind of guide the intensity or how hard they're going to work. You could also think of things like helpful shortcuts, like how many exercises are you going to give them per body part, how many sets, how many reps, and how many times per week are they going to do. We've all got those averages from school or from, if you've ever taken like a National Academy of Sports Medicine course, anything like that. It tells you 6 to 8 movements per body part, 2 to 3 sets for 8 to 12 reps, right, for a generic strength program. Lastly, methods. So these are techniques or strategies of credence, and we should think of them as what is the intervention. So things like this would be resistance training, reps in reserve, RPE, so rate of perceived exertion, or percentages of volume or how much activity they've done.
All right, so discharge planning. We're going to talk about how we get from our first visit to our last visit. So first thing we want to talk about is when does discharge planning begin? And the truth is that it begins right away at your initial evaluation. During your initial evaluation, you're identifying criteria for discharge, and that's going to be a balance between the patient's goals and then also your expectations. So that's your objective knowledge of tissue healing times and things like that, but also your anecdotal evidence of how long you think this should take and what they should look like within certain periods of time. So to go back to the principles, heuristics, and methods, our principle here, what guides the intervening, so what's guiding our discharge planning. So this we can consider as our restore. So we want to restore prerequisites, so restore the prerequisite range of motion, strength, to achieve certain movement patterns. So then we want to restore movement patterns, which means that we need to use our range of motion and our strength to establish motor control over different patterns. And then we want to restore our ability to manage force. So that's both to create force and distribute force. And then once we kind of hit those buckets, then we can start thinking about when we're getting ready for discharge. For our heuristic here, we're thinking about what needs intervening. So those are our buckets of need that Rich mentioned: range of motion, strength, elasticity, locomotion, things like that. And then our methods are what are the intervention. That's our plan of care. So therapeutic exercise, therapeutic activity, neuromuscular re-ed, manual techniques, gait training, a home program, a gym program. Those are going to be our methods as we go through treating a patient. So in order to get from initial evaluation down to discharge, we need to identify our indicators of success. So we're going to have objective indicators and subjective indicators. Our objective indicators are our restore range of motion strength, like we talked about. You're going to have an idea based on your clinical expertise where you should be when you're getting ready to discharge. So our total knees, obviously a very easy one. It's very objective. If we're over 120 degrees of flexion, we're making our good progress towards discharge. It's going to be hard to discharge someone at 95 degrees and have a happy surgeon. In this context, I want to talk about strength as more of a relative term. So we're thinking about strength as the ability to produce force in order to achieve a task. It's what use is it if they have, 100 degrees of grip strength on a dynamometer test, but they can't open a jar. So this is restoring the strength and the ability to do daily tasks and to achieve goals. Then we want to make sure that we're restoring the coordination of the movement options that we've created. So this is rolling, sitting, standing. These are kind of foundational movement patterns. We might have the strength to do it, but not the coordination. So that's the next step after we've kind of restored the prerequisites. And then finally, restoring our ability to manage force. So now, are we able to demonstrate the motor control for the task, but can we create enough force over a period of time? So this is where power starts to come in. So creating force with that time component equals power. So if you think standing from a chair, going upstairs, you need to be able to generate force and also over a quick enough period of time that you can achieve that task. The next thing we're going to consider as we're building our programs, our plan of care, is different barriers to the patient's success. So first we can talk about adherence and motivation. I think that a lot of times we miss the mark here as far as creating a perception of value. We have a lot of patients, not a lot, but we have those patients that kind of fall off where the plan of care starts to get lost and they stop coming to therapy. A lot of times it's because they don't see the value in it. So making sure that the patient's perception of value is always there. We're always kind of touching home on what's important to them and showing them how they're making progress and how our care is helping them. That will help with their adherence. Can't always help with motivation, but we love the motivated patients. They're the easy ones. The next thing we want to think about is access and resources. So those are more physical barriers to success, whether it's they don't have transportation or it's challenging for them to get to the clinic is far away, they only have 10 visits of PT per year, they have a $90 copay, all of those things. And those are things that we're going to have to work around because patients are still going to need care and they're going to need our help even when we have these barriers. So identifying the best way that we can care for them within those constraints, that's all going to be part of our plan. And maybe that's going to accelerate discharge if they have a big access barrier. The next thing I want to talk about is reassessment. I've been talking about this a little bit lately. I talked about it in our billing course a couple weeks ago with the mentors. I always create a 4-week plan of care, and that's mostly just keeps me honest. I'm not going 6-8 weeks forgetting that, oh, maybe I should check in on this patient's goals, or you go a few visits when they're kind of throwaway visits because you're following the same program, you're not really ready to progress anything yet, and then all of a sudden a month or so goes by and you forget to check in. So creating that plan of care, my flow sheet or my Epic tells me that their plan of care is up, so like, oh, okay, let's check in with their goals, let's make sure that we're moving in the right direction. That's gonna have an expectation at that point. So I expect to be wherever I am in those 4 weeks. For the most part, I'm gonna see either the progress towards what I'm looking for, we're gonna be stagnant and I'm gonna have to figure out why, or we're going in the wrong direction. So during this reassessment, I'm thinking about what's next. Am I gonna continue PT? So am I gonna iterate what I'm already doing by either changing up the program or progressing the program because we're on the right track and they just need some more time? Are they not really making a ton of progress and I need to try something new? And then the next, obviously, continue or discharge. So now we're discharging if maybe it's time to send them back to the doctor, they need further evaluation, they're not benefiting from our care, or maybe that we need to refer out to another specialty because we think that maybe the problem's not necessarily musculoskeletal or something that's within our scope. Then we can also discharge and transition to an independent program. And we're gonna know that we're ready for this once our buckets of need are filled and the patient is demonstrating good independence. So they're feeling like they have good confidence or self-efficacy to continue to manage their symptoms and manage their program on their own. And also their ability to manage setbacks. It's important to make sure that you're talking with their patients about the expectation for setbacks and how to manage them so that if a flare-up of symptoms happen or something like that, they don't just freak out, run back to the doctor, run back to PT, stop doing whatever you told them to do for 3 months, and then you see them and they're like, oh, I had to have surgery because my knee started hurting again, so I stopped exercising. What I kind of want to address here is, as we're discharging patients to independent programs, I think that a place where we're really missing the mark is we're giving them a program that is really just a continuation of therapy. So we're giving them more rehab exercises to do, kind of without a plan for progression, a plan for them to ever finish doing these rehab exercises, and then also not addressing the rest of them as a person. So I think that it's important, and that's why we built this course, is identifying ways that we can create a more generalized exercise program that is promoting more physical activity, so that they can address their problem that they came to us for therapy, but also they can improve their overall general health so that musculoskeletal injuries and musculoskeletal complaints are better managed, as well as other non-communicable diseases. All right, so this is our favorite quote. Rehab is simply the training in the presence of injury. If you've ever been to a course that I put on, or a course that Chris put on, we're gonna address this quote because it's our favorite. We're gonna take a look here, and we're gonna talk about what is training. So training is the activities to promote return to meaningful activities. So is training always for an athletic event? No. Is training always for a sport? Not necessarily. If we kind of look at our general population of the patients that we see, sure, some people are trying to get back to athletics, but a lot of them are just trying to get back to their regular life. So if we look at training for life, then we can start to modify some of our ideas around exercise and how we're prescribing it upon discharge. So if you see here, this graph happens to be ACL surgery as the example, but on the x-axis we have time. You see in the early phase of rehab, so whether you're just recovering from an injury or a surgery, we have lots of rehab exercises. And then as we get further and further away, our activity looks a lot more like training. But if you see, there is some element of both throughout most of the timeline. So we're able to introduce, even if it's just a tiny little bit, we're able to introduce some training even early in the rehab. Usually it's by addressing tissue that's not involved in the acute injury. And the picture here kind of shows the progression from a box squat to a barbell loaded back squat. So a rehab exercise versus a traditional training exercise. So during the early phases, when we're doing a lot of rehab, we're thinking about those restore principles that we talked about earlier. All right. Some considerations when building a rehab program. So these are our plans of care. We're considering tissue healing time. We're considering functional limitations. We're considering physical impairments. And our goals are protect the healing tissue, to restore function, and resolve deficits. Then, when we're building a training program, our considerations are the patient's training history, so that's basically any type of exercise history, their personal preferences as far as what type of exercise they like to do, what sorts of movements they like to do, and then also we're going to go back to access here. Again, now we're talking about what kind of access to equipment they have, what kind of access to a gym or other resources. And our goal is to restore participation. And again, it's not just participation in a sport, but it's activities that are meaningful to them, and it could just be any daily activity. All right, so now we're going to talk about physical therapists as health promoters, and our principle here, so what guides us is to increase physical activity in our population, so adults and adolescents is the primary. We don't see a lot of young kids, we don't see, but adults and adolescents. So according to the World Health Organization, physical inactivity is the number 4 global risk factor for premature mortality and predisposes all of us to a wide variety of chronic diseases, heart disease, hypertension, stroke, diabetes, cancers, and frailty. And that's all just related to physical inactivity. We can use the term insufficiently active versus sedentary as a little bit of a distinction. A lot of people, most adults, have sedentary jobs. So they're sitting for 8-10 hours a day between their job and their commute. But they might also meet all the physical activity guidelines, so they get their recommended aerobic and resistance training activity throughout the week. So even though they have a sedentary job, they wouldn't be considered insufficiently active. So making sure that we make that distinction for people who feel like work is a big barrier and like, oh, I'm just sedentary anyway, kind of really highlighting the importance of adding that physical activity in so that they can hit those markers. 31% of adults and 81% of adolescents are insufficiently physically active, so they're not hitting the recommended allotments of weekly activity, and again, that's predisposing them over time to all sorts of chronic diseases. And musculoskeletal injury and pain is one of them. So we talked about the chronic disease risk, and then it's up to a $27 billion per year healthcare cost. So it's a real burden also on our healthcare system, the physical inactivity, and then the associated non-communicable diseases. So where do we fit in here? So as physical therapists, we are experts in movement, function, and exercise. So we can integrate the scientific principles of movement, function, and exercise to be great healthcare providers, to allow for prescription of effective and individualized exercise programs that can be safe and allow people to feel comfortable getting into some sort of physical activity. I know that I can speak for myself, I think I can speak for Rich when I say that the reason I became a physical therapist was because I wanted to be able to help people. I thought it was a great way to really make human connections with people. We get to spend a lot of time with our patients, and if we play our cards right, we can really have a big impact on their lives. And I've found over the years that these people that I can influence to have a big behavior change are kind of the most rewarding patients. Everyone kind of gets better from their surgeries, or they don't. Everyone kind of gets better from their injuries, or they don't. People come and go, their motivation level, but it's those people whose lives you really touch and you really are able to create a change with them. Those are the people that you kind of remember and sticks with you. And this is a way that we can really make a big difference in people's lives. A study of primary care physicians, so obviously not healthcare, not PTs, but PCPs, found that it took counseling 12 patients to get one to create an exercise program that they stuck with for a year. So that's 12 interactions with exercise counseling to get one patient to adhere, which is much, much higher percentage than most other behavior change counseling for primary care physicians. We spend way more time with our patients. We're exercising with them already. We have a lot more influence over their activity and their decision making, and we see a ton of patients. So if we, on average, see 12 patients a day, you figure 3 to 5 patients a week you can probably get to start and sustain an exercise program for a year. And if we're all doing that, and we're all doing that in our communities, you can kind of see how that extrapolates into greater population health, and how maybe my one exercise program doesn't feel that important, but as a group and as a company, we can have a really huge impact on the population health in our area. So some of the barriers to our ability to do this are low confidence and insufficient training, both in our abilities to, our low confidence in our abilities to incite behavior change, and also our ability to have to create good individualized exercise programs that are more generalized and not quite so nitty gritty and really focused on patients' specific problems. In 2021, a multinational survey showed that about 50% of PTs felt like they didn't have the sufficient training or knowledge to prescribe exercise, general exercise, not just exercise obviously within the clinic, but general exercise. Another barrier is that was found was personal experience. So what are we doing outside of work as our physical activity? What are we being exposed to? Are we influencing patients to do things just because we prefer to do them or because we feel comfortable doing them? The more physical activity we expose ourselves to, the more experience that we have, the more personal experience, and we can feel really comfortable being like, hey, this is going to feel like this, or if you try this, this is what it's going to be like. I know that I've lived in the town that I've worked for the majority of my career, so I have been to most of the gyms in my town. So if someone's like, oh, I'm going to this gym, I'm like, oh yeah, then there's this piece of equipment or like this trainer, and like being able to have that little bit of a connection is really helpful to making patients just feel more comfortable, not only as me, a healthcare provider, giving advice, but also me as another person being physically active, being able to give advice. All right, so this is our heuristic, our simple rule of thumb for building an exercise program. 150 to 300 minutes per week of moderate intensity aerobic activity, or 75 to 150 minutes of vigorous intensity aerobic activity, or some combination of the two, and muscle strengthening activity on 2 or more days per week. Those are the numbers, easy to keep in your head, simple rule of thumb. You're not sure where to start, this is a great place. The guidelines aren't perfect, but they're a simple way to start, and as we saw on the previous slide, only about a third of adults are hitting these markers, so something's better than nothing. We're not going to let perfect be the enemy of good. Another criticism. So some common barriers to adults exercising are resources, time, and knowledge or confidence. So that's where our role comes in. We might not be able to create time, obviously, for our patients, but or the resources, but we can definitely give them strategies to find some time or to create little movement snacks or different ways that they can start increasing their physical activity, and give them things that are accessible, easily accessible at home. And most of the time, our patients trust our base of knowledge. They've been exercising with us for, at least a few weeks, maybe even longer. So they can trust us to build them a program that's going to be both effective and safe for them. And the physical activity guidelines for adolescents is a little bit more broad. 60 minutes of moderate to vigorous activity per day, which includes aerobic activity at least 3 times per week, muscle strengthening activity at least 3 times per week, and bone strengthening activity at least 3 times per week. Again, for kids, it tends to be a little bit more activity-based. So are they moving rocks around in the yard? Are they playing their sport? Are they, what are they doing, playing with their friends? Are they jumping up, jumping rope? Are they playing hopscotch, jumping off the swings? Anything like that. Those all kind of add up. It's much less important for kids to have that kind of leisure time planned exercise the way it is for adults. They kind of can just, most of their physical activity of that 60 minutes will come from play. All right, so the meat and potatoes of this is how to build an exercise program. Does anybody have any questions about anything so far? Okay. So we're going to use the FIT-VP model. It's a NASA?
ACSM.
ACSM, the American College
of Sports
Medicine. So FIT-VP, FIT, frequency, intensity, time, type, VP, volume, and progression. So like building a rehab plan, we're going to identify our buckets of need, and we're going to identify our indicators of success and our barriers to success. Our goal should be to create a program that not only allows for, like I said, not only allows for continued recovery or a continuation of their PT, but it is an exercise program that will promote long-term health outcomes and achieve the recommendations that we, for physical activity that we talked about in this previous slide. There are many ways to skin this cat, but the focus of each exercise program should be to increase strength, increase lean mass, and increase cardiorespiratory endurance, as those 3 factors are most correlated with managing chronic disease and improved health outcomes. All right, so now we're moving into our method, which is build an exercise program using the FIT-VP framework. So our principle was increased physical activity, our heuristic was the physical activity guidelines, and our methods are exercise prescription and FIT-VP. It's just one of many, but it's a very simple one that we can all remember. And it's pretty systematic. So as we start to automate this process, it becomes easier, it becomes less of a time burden on us to start creating these programs. So for frequency, these are all kind of listed out in the FIT-VP framework. So frequency of aerobic activity, 3 to 7 times a week. The intensity is moderate to vigorous. The time is 20 to 60 minutes. The type is patient preference. The volume is 75 to 300 minutes per week. And the progression is adjust the above variables to increase volume over time. For resistance training, frequency is 2 to 3 times a week. The intensity is 60 to 80+% of 1 rep max. The time will be variable, the type will be preference, the volume will be variable, and then we're adjusting variables to increase intensity for progression. So according to the American College of Sports Medicine, or is very easy resistance training prescription, 2 to 4 sets of 8 to 12 reps at 60 to 80% of 1 rep max with 30 to 90 seconds between sets. That's per exercise. Your goal is going to be to increase intensity while maintaining a consistent perceived effort. So if you're lifting 100 pounds and you consider that an RPE 6, and then the next week you do the same lift and you lift 150 pounds, but it's an RPE 8, you haven't actually gotten any stronger, you just changed your intensity. So you just changed your goal for the exercise for the day, which is why it's important to make sure that when you're giving the exercise prescription, we're being not specific, but we're being intentional about our intensities. For aerobic activity, 5 days a week, at least 5 days a week of moderate intensity activity, or at least 3 days a week of vigorous intensity activity. So again, that's why we have those variables, or a combination of both on 3 to 5 days per week. You want to, with the lower intensity of moderate, 30 to 60 minutes per day versus vigorous, you're going to look at like 20 to 30 minutes. So you're going to work for a little bit less time, but you're going to work a little bit harder, and it's all going to feel terrible because aerobic activity is not fun because I hate it. This it includes exercises that work the major muscle groups in a continuous pattern, so running, elliptical, cycling, swimming, things like that. And the goal here is to increase the volume while maintaining consistent perceived effort. So if I'm walking for 20 minutes, can I go further in that 20 minutes with the same perceived effort? All right. So some considerations for aerobic exercise prescription. Most adults that are active at all are hitting the aerobic mark. That 31%, the majority of them are hitting the aerobic portion, and missing the resistance training portion. So a lot of times we don't have to dial this in a whole lot. Maybe we can give them some suggestions about how to increase their intensity or increase their volume over time. But just checking in, making sure that they're doing their aerobic activity. Maybe we need to change what they're doing based on their injury. But otherwise, if they have an aerobic program, let them do it. Keep things simple. What we want to think about here is start low and go slow. So think about the insufficiently active population. You're not going to give them, 150 minutes of vigorous intensity aerobic activity right off the jump, because they're going to do it for 1.5 days and then they're never going to exercise again. So it's not a great place to start. I like a lot of times what I like to do is I like to introduce aerobic exercise with intervals. So some bout of effort with some bout of rest, whether that's varying the intensity of the effort or it's an effort and then a true rest, depending on how deconditioned they might be. I might start them with something that feels like a little bit lighter as far as their effort, and I might start them with 10 minutes 2 or 3 times a week. Is that the guideline? Is that the goal? No, but it's somewhere to start. So the other thing to remember about this is kind of like eating. You have to exercise forever. You can't just bank all your exercise and then stop at some point. So as you're creating these programs, it doesn't need to be perfect today. It doesn't need to be the guideline or the goal today, but just creating something and then allowing it to have room to grow into eventually the guidelines. So starting low and going slow. The intensity is going to be relative. So someone who's highly trained is going to their RPE 4 or 5 is going to be someone who's trained. It's going to be their RPE 10. So we just want to make sure that we're not prescribing the same types of exercises to all our individuals, and that's why we're taking training history into account as we're prescribing. Thinking about inter-session recovery, so that's maybe the use of intervals. Also intra-session would be intervals. Inter-session would be how many times a week. So if I'm just introducing something, I'm probably going to give them 2 days of rest. I'll probably give them Monday, rest, Tuesday, Wednesday, try again on Thursday. That gives them the ability to fully recover, but it also gives them the ability to take a couple of days to reflect on how their body feels. So is their injury flared up? Does it take 12 hours to recover, 24, 36? Does it take the full 2 days? Are they ready to exercise again on that 3rd day? Having that kind of self-regulation is going to be important for people to continue to feel comfortable exercising over time. It's something that I use a lot during my plan of care. So whether in my care, I'm giving them something on Monday when they come, and I'm, pay attention over the next couple of days and track your symptoms. They come in on Thursday, we talked about it. All right, how did we feel after Monday? I felt really bad for the rest of the day on Monday, but by the time I woke up on Tuesday, I was back to baseline. Or did it get flared up and stay flared up for 3 days? For progression, I like to go by the 10% rule. So whether it's volume, intensity, duration, trying not to increase by more than 10% at a time. Again, giving that as a really simple rule of thumb for patients when they're progressing their own stuff. That will reduce the risk of developing overuse injuries, because that tends to be what happens as we let people go off on their own. Now for resistance training prescription, we're going to have a little bit more to consider. First thing is going to be barriers. So the biggest barrier here is going to be equipment access. Not everybody wants to go to a gym. Not everybody has enough equipment at home to create enough of a stimulus. And then we also have people don't want to resistance train. So really kind of highlighting the benefits of resistance training, why it's important to maintaining a well-rounded and healthy life. is going to be important, and that's something that we can start obviously during our sessions. Exposing them to resistance training during PT is a great way to just get them kind of interested and get them feeling comfortable with it. This is where we're gonna, during PTs, we're gonna address a lot of these barriers as far as exercise preference and fear around certain exercise and movement patterns. Exposing, so someone who's scared to deadlift because their uncle, blew out his back and had to have a spinal fusion because he deadlifted one time. You can tell them until you're blue in the face that the research doesn't actually suggest that you're gonna have an injury while you're deadlifting. The likelihood is pretty low. But exposing them to deadlifting in a gradual fashion and making them feel safe and comfortable doing it is going to be way, way more effective. And that's, again, we're going to use our plan of care and our PT to start moving them in that direction if that's something that is going to be important for their long-term health, which it probably is because people need to lift stuff up off the ground, I think. We all know that, in general, eccentric exercise tends to be create more DOMs. So when we're first introducing exercise, trying to limit that so that people aren't too sore and they have that negative training experience. Isolated movements also tend to cause more DOMs, so focusing on using compound movement patterns maybe when we're first teaching exercise and first prescribing, so that it's more comfortable. Rest and recovery, same thing like we talked about. It's whether we're resting between sets, we're resting throughout the week, making sure that we have enough time in between each session to recover, to identify how our bodies feel. And then we're going to use RPE or reps in reserve primarily for measuring intensity because this correlates well with 1 rep max without actually having to have somebody do a 1 rep max, which requires a lot of time and knowledge and motor control and all sorts of other things that no one really has time for unless a 1 rep max is their goal, but they already probably know how to do that. Another measure that you can use is just, did that exercise feel hard? Did it feel very hard? Was it moderate? There's also some correlation between those and RPE. So there are some really easy self-regulatory methods to identify intensity. Practicing them in the clinic to get people to be more confident with them and to kind of dampen that learning curve a little bit. Then the 10% rule again for resistance training. Now instead of using volume, we're going to use load volume, which is the weight times the number of reps. So if you're squatting 100 pounds 10 times, 1,000-pound load volume, you don't want to increase that by more than 10% on any given week, and that'll be per movement pattern. In order to maintain the principles of progressive overload, it's probably going to be beneficial for people to track what they're doing. So whether it's keeping, having an app or a journal where they're writing down their sets and reps and their weights, as well as their RPE, those are going to be important things to monitor to make sure that the progression is appropriate over time. That also allows us to look at that 10% rule. It allows us to identify any acute increases in training volume that might also be associated with a little bit of an overuse type injury or kind of little onset of symptom flare-up or some kind of pain.
It can be kind of an endless topic of debate. What are the fundamental movements, squat, this, that. We chose the National Academy of Sports Medicine for the foundational 6. So what we're going to cover today are a squat, a lunge, a hinge, a push, a pull, and a carry. You might have heard them in any other different fashion. There could be 4, there could be 8, it all depends. But for today's purposes, to make things easy, this is what we'll use. This is our principle. So we're going to cover resistance training. So for the squat, the general idea is generating force, I'll stay out to extend the knee and the hips upward. So an example would be a goblet squat. The trunk will flex forward, right? But goal is going to be to keep the trunk up as much as possible. The progressions and regressions in a therapy lens, what we really want to consider on the base level. Obviously, we talked about the fit behaviors level, so there's tons of ways through frequency, intensity, time, type that we can increase the metrics here. But really, in a PT lens, probably the best way to do it is think how much range of motion are we having to go through. So are we starting with a mini squat for a total knee versus a full depth? Are we choosing which anatomical planes? Are we having them do it on the leg press and more of a horizontal push for the squat? Are we having them stand up, so forth? And then lastly, is it on both sides versus one side? Are we trying to load more? Do we stagger? Do we have kind of partial in between? Lastly, considerations and points of performance. We want to think about cueing, keeping the chest up, hips back, and then ultimately trying to get the hips below the knees for the squat pattern. Next up will be the lunge. So the basis for the lunge is going to be generating force to propel the body in a specific direction. So although we think of like a static lunge or a split squat, you're still generating the body upwards in a specific direction. An example that we see commonly in therapy we're going to use often is a step up. We will complete this after. So progressions and regressions are really limited by our imagination. We can choose to do as crazy as possible or as basic as possible. So we can take something from a split squat to a lunge jump, right? There's still the same foundational movement, but the intensity has been changed, the time, the type, the outcome, the stimulus, etc. So considerations for points of performance here are, again, to maintain an upright chest, to drive through the back leg and keep the hips level. Next up is the hinge. So we're going to be working on generating force to extend the lumbar spine, hips, and knees upwards. In this pattern, typically we're going to have the hips higher than the knees. And then obviously we know, again, there are multiple variations of this. So a conventional deadlift, you'll get a little more knee bend. In an RDL, you're going to have a little less knee bend, all within that progressions and regressions. The example provided here is an RDL, right? So the spine is nice and upright. We have a slight bend of the knees. As we're coming down, again, the hips stay taller. Once again, progressions and regressions here, range of motion, anatomical plane, and unilateral versus bilateral. Like I said, I'm sure all of you have had that patient where you're like, this just isn't challenging. They're getting bored. Use your imagination. You kind of don't need me to tell you how to progress things. Points of performance here are going to be to sit back, we'll describe, and then keeping the back flat. So you want to think about almost telling them, not quite that pelvic tilt, but creating some pressure in their low back or in their core. And lastly, excessive lumbar flexion. So again, the cue or heuristic where that would be to maintain a kind of tight spine versus letting that lumbar flexion happen. The push, we're going to be generating force to move something away from the body. The example here would be a floor press. So common, again, therapy variation, starting people to get back to pushing. We're going to lay on our backs, elbows at our sides. We have a nice back stop from the floor, and we're going to press upwards, lining up with our hands over our shoulders.
Vertical push is also going to be included here, so that would be anything pressing overhead.
Considerations for points of performance for this are going to be drawing the shoulders back, creating a little bit of tension as we drive the arms upwards, avoiding excessive thoracic extension, so trying not to compensate too much, and also getting full elbow lockout. So some cueing for that could just be squeeze the shoulders back before you start, lock the elbows out, pretty simple. For the pull, we're generating force to move something towards the body or move the body towards something. The example we're going to cover today is me a bent over row. We also have
Lat pull downs.
Lat pull downs.
So that would be a vertical pull. So you're pulling either your body towards an object or pulling an object from overhead down towards your body.
So some progressions and regressions, again, we can increase weight. We'll keep it simple for that. But considerations of points of performance are for the pull are going to be getting that full protraction of the shoulder blades, getting full movement as we retract backwards. Having rounded shoulders just could be some weakness. So again, just cueing shoulders back as if they're carrying something heavy could be a helpful cue there. For the carry, we're generating force, once again, to hold something at or away from the body. The example we'll cover today is a farmer's carry. So shoulders back, holding a weight, walking for any predetermined distance. Carries be modified to reduce range of motion, improve stability, so we can change it to a box carry, keep it closer to us, less range of motion on the shoulders. And they can be performed in any plane, but typically we'll be prescribing these in the sagittal plane. Not very often we're having someone flail their arms around as they're carrying something. Common faults for points of performance here are scapular traction and grip strength. So those are the main things you want to make sure that the patient has as a prerequisite to perform the movement. Common faults can be, again, rounded shoulders, simple shoulders back and down, or asking them to put their scapulas in their back pocket can be a helpful one. And then lastly, swinging arms. I like to prescribe saying, imagine you're carrying 2 pans of paint over new floors. People kind of tighten up a little when they do that. They can have that flashback to their first like homeowner project, and they ruin the floors. So we're going to break out into some functional or foundational movement stations. We have 6 stations set up. What we're going to cover is the front squat, for the squat, the back squat. We're going to cover the lunge and a reverse lunge and step up. Hinge will be the good morning and the deadlift. Push will be dumbbell bench press and a dumbbell strict press. Pull, flat pull down, dumbbell row, and carry, a farmer's carry and a midline carry.
All right, so now we're going to start to talk about managing some setbacks. We can expect to have setbacks as we become more active and more intensively active adults. We can expect that some things are going to hurt sometimes, and that's okay. So really having a lot of conversation around hurt versus harm is important while you have their ear, so during their plan of care, having those conversations frequently. But then also giving them the tools to manage any setbacks, but to identify their response to their activity. So we're going to just look at some signs of overdosage or overtraining. We can look at a new onset of a pain. I like to call them niggles. It means if something kind of hurts a little bit, it's a little bit bothersome, but you're not injured and you're not going to stop doing what you're doing. Maybe you're just going to modify things. Another sign of an overdosage of exercise or an overtraining is prolonged recovery between sessions. So now you have your 72 hours between your sessions. You're not really fully recovered and ready to go, whereas 2 weeks ago you could go every other day. So you're starting to see that your recovery time is taking longer. You have decreased energy overall throughout the day, and your performance is decreasing. So what used to be an RPE of 6 is now an RPE of 8. So if you start to notice that pattern over time, those are some signs of overdosage or overtraining. Oh, so the pain and activity traffic light I like to use as a guide to movement. So green means that everything felt great. Great, continue doing that exercise at that intensity. Yellow means that you had a little bit of a change in pain that lasted a little bit longer than you wanted. Maybe you let that ride for a week or 2 before you have to start making any modifications, but that's something you're just kind of paying attention, a little bit closer attention. And then red is you have a significant increase in pain, you have a sharp decrease in function, loss of performance, pain is now lasting a lot longer, 3 days, 5 days, 7 days after something. This is not a sign that you should stop all activity. It means that something that you did was a little bit too much, your body wasn't ready for it. We're going to identify that thing, remove it for a short period of time while continuing to train. So the idea of training around pain and around symptoms is something that's going to be very important. The onset of one symptom or one body part being aggravated doesn't give license to just completely not being active at all, but figuring out ways to be active around that problem. So some things that are modifiable training factors are the load, the effort, the range of motion, the speed, the frequency, the volume, the rest times, and movement variation. That's a lot of things that you can change if you're in the yellow or red category and continue to exercise. So whether you're doing a lighter load, whether you're bringing your RPE down, whether you're tightening up your range of motion, whether you're moving faster or moving slower, whether you're decreasing your frequency, whether you're decreasing your overall volume, increasing your rest times, changing a movement, you're going from using a barbell for your bench press, you're switching to a dumbbell because the dumbbell has more degrees of freedom, so you can get your shoulder or your elbow in a more comfortable position. You're going from a bench press to a floor press so that you're limiting the stress on your shoulder, the range of motion that your shoulder is going through. Lots of knobs we can turn and dials that we can address here to modify training so that we're staying in the gym, we're staying active while we're still addressing maybe a pain or a niggle. Some modifiable lifestyle factors. These are some other things to consider when you're finding that you're having a decrease in your performance. So are we getting 7 to 9 hours of sleep? Are we managing stress? So that's emotional stress. Remembering that exercise, while it is a good stress, it is a stress. And our body can only really handle so much emotional and physical stress. So if our emotional stress starts to get very high, that's going to bleed over into our ability to rest and recover from our physical stresses, and then it all kind of becomes negative. So whether it's meditation, journaling, some other stuff that well-adjusted adults participate in to manage emotional stress, take a vacation, I don't know, don't go to work so much, whatever it is. All these things that none of us actually follow, but modifying our levels of emotional stress can really have a big impact on our ability to manage and recover from training. Another big one that we don't talk a ton about, it's in our scope. We can talk about nutrition. We can definitely have some basic conversations around nutrition. Want to make sure that people are eating enough calories to recover. A lot of times when people are injured, they're going to decrease their caloric intake because they feel like they're not being active enough. They don't want to gain any weight, so they're not going to eat enough. Well, we need calories to be the building blocks to aid in recovery and aid in healing. So making sure that the appropriate amount of calories are being eaten. Making sure we're taking in enough protein. So it's about approximately 0.36, which is very specific. Grams of protein per pound of body weight is what's recommended. The recommended daily allowance is about 0.36 grams of protein per pound of body weight per day. The hydration kind of also plays in there. A very simple rule of thumb for hydration is half of your body weight in ounces per day. And then the last one being general physical activity. In 2019, a cross-sectional study showed that people who participated in general leisure time physical activity had lower risks of low back pain and neck and shoulder pain. So just being physically active is enough to manage some of these musculoskeletal conditions, these chronic conditions that we deal with.